And welcome everyone to this Brain Tumour Support New Zealand webinar, Palliative Care and Hospice Services for Brain Tumour Patients. And I'd like to welcome our two guest speakers, Dr. Salina Iupati and Jeanette McLaughlin, who are joining us this evening. Dr. Salina Iupati is a palliative care specialist at Te Omanga Hospice in Lower Hutt, where she provides care to patients with terminal illnesses. Before that, she was a GP for 10 years. Salina is a PhD candidate at the University of Otago, researching a future model of community specialist palliative care in Aotearoa. Salina is a current member on the training committee of Royal Australasian College of Physicians for Palliative Medicine and a committee member of Palliative Care Aotearoa Research Network. Finally, Salina is a valued member of the Brain Tumour Support New Zealand Medical Advisory Board. And joining Salina tonight is her colleague at Te Omanga Hospice, Jeanette McLaughlin. Jeanette has worked in palliative care for 10 years and has expertise in the delivery of excellent palliative care to patients in whānau. She's also the bereavement coordinator at Te Omanga Hospice and provides support to bereaved whānau and friends. Jeanette's previous roles include oncology social worker at Capital and Coast District Health Board, health advocacy, supporting patient rights under the Health and Disability Code, and social worker for children in care in the UK. And Jeanette has an applied Master of Social Work. So, Salina, can I hand it over to you to start your presentation?
Okay, thank you, Chris. Let me just share the screen. Can you all see this? Can you all see the screen? Yeah, okay, that's cool. Thank you. Right, thank you, Chris, for your invitation and to speak. And I'm hoping that just give a general overview of the palliative care services in New Zealand, and then I will leave a lot of time for questions at the end. So Jeanette and I will co-present, so I'll do the presentation first and then Jeanette will do her bit. All right, let's make a start. Hang on, for some reason, we tested it before. There we are. Now, okay, that's good. So this is what we're going to cover for this talk. So I'm going to cover talk about the in general terms of palliative care services available in New Zealand, and a snapshot of what is hospice care, and who and when should access in relation to brain tumour patients, and also map out a typical patient journey, and then Jeanette will cover the practical aspects such as like respite care and support in the community, and then as I said, they will cover leave plenty of time for some questions at the end. So what is palliative care? Palliative care is the care of people who have life-limiting and progressive illness. And the services in general can be separated into primary, the generalist palliative care, and specialist palliative care services. Now, the generalist palliative care providers are those whose work are not solely in palliative care, and they have not received specialty training in palliative care, so they have non-specialist palliative care skills. So most of so all GPs and primary care team and oncologists and other specialties, and district nursing services, they all have non-specialist palliative care skills. In actual fact, palliative care is covered as, for example, in medical school, in undergraduate program, and also in postgraduate training. Anyone in the hospital who have looked after dying patients would have a generalist palliative care skills. And the specialist palliative care services are provided by practitioners who solely work in palliative care services. We received advanced or specialist training in palliative care. So for instance, for palliative medicine, physician training, there are two ways of becoming a palliative care physician. The one way is through they're both ways through the College of Physician, but the pathway, one of the pathway is along the physician training pathway, like other specialty, such as oncology or cardiology, is a similar sort of length of training. And the other pathway is the pathway I took, which I finished my training in general practice and worked in general practice for some time, and then did another 3 years of training through the physician training college to become a specialist. So the specialist services care for patients with more complex needs, and that the complex needs is something that is quite variable, depending on different factors, actually, depending on some local factors of other services as well. So the cornerstone of palliative care is multidisciplinary, which means that more than one profession is involved in the team. And in New Zealand, the specialist services reside either in the hospital as a hospital palliative care team, and in general, the team consists of a doctor and a palliative care specialist and clinical nurse specialist. And in the community, the specialist services are covered by hospices. Now, the hospice care in New Zealand are covered by 33 hospices across New Zealand. Now, 32 of the 33 provide clinical services, and one provides funding. There is quite a variation across the country, and all hospices provide combination of home-based care, and some hospices have inpatient beds. So as part of my PhD, I surveyed all the hospices in New Zealand to get a snapshot of what is being provided. And so I'm just going to show a few of the slides that come from the survey. There are, so as you can see from this slide, that not all hospices have inpatient beds. So only 19 of the 32 hospices have inpatient beds. And as you can see, there are not even those who have inpatient beds have the number of inpatient beds are not many. In actual fact, they are less than a lot of the residential care facilities. And 13 of the hospices actually don't have inpatient beds. So their care is takes place in patient's home. So who work at the hospices? What professions do they employ? As you can see from this slide, most hospices have nurses, the vast majority, and then followed by doctors as well, and then social worker and complementary practitioners and counsellors. Now, not all hospices, in actual fact, I don't think there are hospices that will employ all of these health professionals. So that will be a combination of these health professionals in each hospice. For instance, in Te Omanga, we don't have psychologists, but we do have OT, physio, social workers, and a pharmacist. Now, the pharmacists are usually employed if the hospice have an inpatient unit. And they're quite but most of the hospices do have a chaplain, either on site, or they would have the chaplains as an off-site provided by another service, but come in to see patients, or to see patients that are under hospice services. So they're contracted from outside. And what are the purpose of care? What is the purpose of care for hospice? So as you can see, all the hospices provide symptom management What that means is physical symptom management, to manage symptoms such as pain, nausea, vomiting, bowel issues. And all hospices also provide the family and carer support, and I would, and Jeanette would cover that topic. And all hospices also provide bereavement care. Now, the bereavement care can be complex or non-complex bereavement care as well. And some hospices also provide bereavement care to children, and including complex children pediatric bereavement care. In terms of the respite care, just over half of the hospices actually provide respite care. So as you can see, there's quite a bit of variation. Now, how does referral happen? Now, referral usually from other from other services, predominantly hospital, occasionally primary care. And usually the oncology service is our biggest referrer. And the referral can be from nursing team, can be from doctors, or from social worker, from GP. There's multiple sources of referrals. And once we receive a referral, then the referral is triaged by a team. At our hospice, we have a multidisciplinary team model. So we have a social worker, ourselves, a doctor and a nurse, usually at the triage team meeting every morning, and look at the referrals that come from the day before, the previous 24 hours. And some hospices, they have a designated nurse looking at these referrals. And we all have eligibility criteria to see whether these referrals would benefit from hospice service. And if the referral looks like that, that the person will potentially benefit from our service, then we will make contact. And we all need, and all the referrals will need to be stipulated, say that the patient has consented for referral. Otherwise, if that is not clearly indicated, we usually go back to the referrer to ascertain, to make sure that a consent has been given. And sometimes if the referral does not have enough information, we will have to go back to the referrer to get more appropriate information. And so once a referral is accepted, then the initial assessment will be arranged with the patient. And usually that would be in the form of either a nurse visit or a doctor visit or both. But if the referral is for psychosocial care, then a counsellor or a social worker will be the first person to meet the patient. And then at the initial assessment, that's when the decision is made whether hospice care will be beneficial, or whether it's a single intervention like giving some medication advice or helping with advanced care planning, and then the patient will be referred back to the primary care. Or if the patient needing ongoing care, then we'll accept it under the program. Now, there's different pathways or different ways that the hospice can provide care. It can be round the care can be round the clock, i.e. 24/7. i.e. the patient can contact the hospice 24/7 for any symptom issue. Or medication issue, that usually when patients is quite sort of advancing the disease and needing a lot of care or a lot of input, or episodic, i.e. usually early on in the trajectory where the patient probably just needs, or the family just need one single intervention and the care handed back to the oncologist or the primary care. Now, all hospices also would, in general, my understanding is that we share care with the GP. They're very seldom that we actually completely taking over care from the GP. primary care team or from, and so we share care with the GP. Some hospices provide after-hours care, and some don't. This is what we found from the survey. Now, who and when should we refer to palliative care? So in general, when the treatment goal is palliative, i.e. the curative options are exhausted, and sometimes referral can be early if there are complexities. And specifically for brain tumor patients, it's palliative care generally referral is done after surgical radical radiotherapy options are exhausted. So these are some of the examples of needs that require hospice input. So as I mentioned before, physical symptoms that persist despite the intervention that primary care oncology or oncology team have put in. So severe psychological distress, or rapid functional decline, and complex communication. For example, in some GPs might need some a hospice team to facilitate advanced care planning discussion, or fluctuating capacity in the context of fluctuating capacity. And complexity in family situation. For example, if there are young children who are finding it very stressful, seeing changes in one of their parents going through, so that could be a reason for referral as well. And equipment need during period of rapid functional changes. So the equipment, some hospices provide equipment, and some hospices facilitate equipment provision using other services. So that can be different across different parts of the country. And also the needs also depends on the capacity of other services, such as primary care, because some primary care team might not do home visits, and but certainly in rural places, the primary care team generally are a lot more involved. Just to give you an example, at Te Omanga, we work with the Kahukura team in Wairarapa. So one day a week, our specialist, medical specialists go over there, go over to Wairarapa to see patients with the palliative care nurses, and the rest of the time, or to give advice to the palliative care nurses and the GP, and the rest of the time, the care is in the patients are in the care under the GPs and the oncologist. So it's more like a consult-based service in Wairarapa. Now, so there has been quite a lot of changes, a lot of development from palliative care since its inception in the 1960s, when the first hospice was established in UK. At that time, palliative care was mainly dealing with end-of-life patients in the last days and last months. But over the last 20 years, there's been a lot of development where increasingly palliative care is involved early on in the disease trajectory. So as you can see, this is one of the models that is sort of depicting the intersection between the disease management treatment versus palliative care treatment. So as the person journeys from a more disease-based treatment, such as chemotherapy, radiotherapy, and surgery, along the disease trajectory where the disease-based treatment no longer becoming effective, then palliative care, the involvement in palliative care increases all the way to the end-of-life care. Now, palliative care doesn't get involved in rehabilitation, but this model involves patients who survived or have long-term survival. Okay, so I thought I'll just give a quite a simplistic view of how palliative care might be involved in different parts of the different stages of a patient journey. So typically someone might present some symptoms such as headache or seizure, and then they present to the doctor, and then the person has a biopsy confirming a brain tumor. And at that point, palliative care might be involved, usually in a hospital, if there are some intractable symptoms or some complex communication that might need palliative care team involvement. And then the person might go on to have surgery. And then after surgery, again, the hospital palliative care team might be called on to see patient once or twice. If there is any intractable symptoms, like needs for like intractable symptoms or complex decision making, and then a person proceed to have radiotherapy, and again, that's another point where the hospital palliative care team might get involved. And at the time of recurrence, that's when the palliative care team in the hospital or in the community, i.e. the hospices, might be asked to get involved to provide support in the community. And when the person has proceeds, if chemotherapy was the right thing, then proceeds with chemotherapy and palliative care team. If the person is not receiving community palliative care team involvement, that's when actually the majority of the referral is at the point of a patient, either at the beginning of the chemotherapy or at the end of the chemotherapy. And the patient is discharged from oncology at that point. So what are the other settings where hospices provide support? We provide support to primary care. Some hospices, like our hospice, we have the primary care team that go out and give advice to GPs and nurses and identify patients that might benefit a generalist or primary palliative care intervention, or who might benefit from referral to us. And we also provide consult service in continual care facilities, like aged residential care facilities. So they see patients with the GP or with the nurses at these facilities, and to provide support and education. And I mentioned the hospital palliative care team. Some hospices have in-reach hospital team, so they are the same, provided by the same provider. And there's the bigger urban centres like in Wellington and Auckland, the hospital palliative care team are different from they are a separate entity from the hospice palliative care team. But even in those situations, the connection and the communication are usually very good between the two teams. And some hospices also see patients in the building, like an outpatient service. And some hospices also have in-reach service into prison, or provide consult service for the prison. And in terms of what I mean by day care, and the day program for patients, like support group or carers group, where there's carer courses where whānau can be provided some training on how to care for their loved ones at home. So this list is by no means exhaustive, but they are the main examples of where hospice service can take place. So I'm just going to touch on a bit of the advanced care plan. And most of you may have actually, come across what advanced care plan is, or been asked to complete one. So an advanced care plan is a document that describes what is important to you, as well as the healthcare and treatment that you want. And it's best to complete with a member of your healthcare team. And you only need to complete the parts that you want, and including end-of-life planning, because some of the questions can be quite confronting. So this is an example of a advanced care plan that you can download from the website. You can just Google it, advanced care plan booklet, and it's very easy to find. And all of us is free of charge. So it's about, I think, at the 16 to 17 pages long. It's quite an involved document. And at the beginning, it asks you some very general questions like what matters to you. So it gives you an opportunity to think about what is important to you and help the health professionals to understand a bit about yourself. And then it also has a page, as I mentioned, that about end-of-life care, and where you can document your preferences. So I can see that there's an option of a hospice, so you can have like a hospital. If some people might want to spend the last day in hospital or in hospital level care, or in hospice, or I don't mind where I'm cared for. So these are options you can take. And in reality, as I mentioned in the survey results, that actually not all hospices have inpatient beds. And even if the hospices do have inpatient beds, the number of inpatient beds is actually very low. So in reality, very few people actually do die in the hospice building itself. And then as health professional, this is probably what we're the most interest about is regarding the scope of treatment, or at the end of life, what kind of treatment that would be compatible with your wishes. So essentially is, modern medicine is good at keeping people alive, or in some situation inappropriately prolonging the dying. So it is good to have a time and space and an option to think about these things, particularly things like CPR. So this provides an opportunity to have a think about those sort of treatment options at the end of life. And so this is another form of, if people don't want to tick the boxes, this is another table where the preference could be documented in a more narrated format. Okay, now I will pass the next few slides, the next bit, to Jeanette.
Thanks, Salina.
Yeah.
So as Serena's already mentioned, hospice services are multidisciplinary, and so I'm just going to talk a little bit about the family support services, and you'll have seen from Salina's charts as well that most hospices have at least some family support services, although it does tend to vary across the different hospices. So primarily I'll be talking about what we have at Te Omanga, which is quite a wide range of service, but the same will be true for most hospices to some degree. So primarily with family support service, we're looking to support the non-medical needs of patients and whānau. So often as a social worker, I'm supporting people around the really practical challenges of perhaps change in finances or change in kind of ability to work and pay mortgages, all those sorts of things. Often we're supporting people to access wills and powers of attorney, and also to access extra support in the community as they need extra help. A large part of our role in family support services is also around the emotional support. So often there are big issues around just grief and loss and adjustment as disease progresses and function declines. So we have counsellors and therapeutic services which are really helpful to support people to process some of those changes. Our occupational therapist and physiotherapist will work really hard to help people maximise their independence and safety. So whether that's through provision of equipment or provision of advice around mobilising and all those sorts of things. The idea is to try and help people to maximise their independence and safety for as long as possible, usually to help them stay at home where that's the desire. We also support people to make meaning of what's happening. So often this is through our arts therapy. So we have at Te Omanga, we have an art and music therapist. I'll introduce you to them later, but other hospices will have a variation on that theme. And so again, it's about walking alongside people and helping people to just make sense of what's happening and to make meaning in ways that are meaningful for them. The creative therapy is also great at supporting children. So a lot of our work is around families with children who are needing support around how to talk to kids or how to manage kids' behaviour in response to illness and stuff in the families. So yeah, I mean, the creative therapy is often really helpful for that, and just also understanding and information around kids' developmental stages so people know what's normal and know what's appropriate in terms of sharing information. At Te Omanga, we have our biography services supported by our volunteers who are trained to do that. But again, that can be a really valuable service to support people to record a biography, which they can leave for their family. And finally, part of my role is within the bereavement support space. So all of the hospices in New Zealand provide bereavement support, and that's a really important part of what we do. Yeah, to recognising that bereavement is normal but unpredictable, and that there'll be a percentage of people who might get a little stuck and need some support in that space. Thanks, Salina. So this is our cottage at Te Omanga Hospice. So our family support team are partly based in this space. That's as our creative space. The rest of us are based in the inpatient unit, but you'll see the list there of the family support team that works at Te Omanga. So we're really lucky to have, it looks like a really big list. Most of us are part-time, but yeah, we're really lucky to have some counsellors, an art and music therapist. There are social workers that we share a role. We also have a Māori liaison support worker who's particularly works with our Māori whānau around culturally appropriate needs. We have our physio and occupational therapist working in those kind of physical spaces. We have a spiritual care coordinator who does some really gentle work alongside people around that kind of existential distress and processing, and also an enormous team of volunteers who do a lot of stuff to support the work of the hospice. One of the things that we do is we also provide groups which run regularly. So I think Salina had already referred to patient and caregiver groups that run. So on a regular cycle, Te Omanga runs a group for patients and also for caregivers to support them in the process of what's happening. So, and the other thing that we run once a month is a bereavement support coffee and chat group, which is a really valuable service for some people who really benefit from connecting with other people who are in that grief and loss space. The other thing that we help people to do is access other support services in the community. So some of you will be aware already that access to most community support services is via a NASC assessment. So all the different regions of New Zealand have different NASCs, but they all work to a similar kind of assessment frame. So all funding goes via NASC, and to access anything in the community, you usually have to have one of those assessments. It's general that people can access a maximum of 14 hours a week of in-home care, and that has changed a little over the last kind of 10 years that I've been in hospice. It's gotten tighter and more difficult to access more home-based supports. It's very based around patient need now. The other thing that is really common for people to access is respite care. So you can access respite care if you've got someone living in the house with the patient, and that, there's a little bit of flexibility around what living in is defined as, but Yeah, respite can look like 3 different things. It can either be a week or 2 in a residential facility, or it can be time spent in day programs, which again are usually at aged residential care. And finally, care support funding through the Ministry of Health, which is a pool of money that people can have to use a lot more flexibly to employ often family members or friends to do tasks to support in that caring role. And finally, if people are needing full-time aged residential care placement, then you do have to have funding for that. And it's different if you're under 65. So there's a different funding stream for people who are under 65, and the funding criteria are different. So my final slide is just a bunch of links that I hope you'll find useful. Like I said before, often we're helping people who've had a big change in income or ability to work and earn. So there's some links there for work and income, just to let you have a look at what you might be eligible to, and also the main payment that people get if they're not able to work due to illness, which is the supported living payment. Some information around getting needs assessments, and also Senior Line have a great link which talks about various things, including moving into care and related issues. I've included the link for care support. I feel like a lot of NASCs don't push care support as much as they could, and I think it's a really useful resource. I think it's probably the most flexible of the support resources you can access, so I'm a bit of a champion for that. And a couple of other things that hopefully you'll find useful, including a flyer that we've put together at Te Omanga around making a will and also enduring powers of attorneys. And I know that somebody did have some questions earlier about enduring powers of attorney, so maybe that's something we'll talk a little bit more about.
So I'll just stop sharing and I'll hand it back to Chris. Thank you, Jeanette.
Thank you both. Jeanette, just while you had that last screen there, the links that you had, what I'll try and do is email all those links out to people who are on the call, because I think they're really quite useful.
Sure, yeah.
Okay, thank you both for the talk. We have a good amount of time for questions. So can I just ask everyone again to type their questions into the question box? I'll get to some of these questions now, but keep typing them into the box, and or yell out if I haven't asked your question properly, or if you have any follow-up questions. So let's have a look here. Actually, I've got one question before I get to the ones that are typed in the box. One for you, Salina. You mentioned about the triaging for the referrals to hospice and the eligibility criteria. Can you expand on what those criteria are? Because a lot of people, I think, are wondering, is it the right time for hospice yet? What state do I need to be in before hospice can take me?
Yeah, I think in general, usually when the life, for patients who actually have a life-limiting illness, like usually it's about the last 12 months, and with complex symptoms. And the complexity can be quite hard to define. And in general, it's like when the GP or the oncologist, for example, the symptoms are beyond what they can manage, then they will make the referral. If you need some extra counselling support, that would be the time for one of the indication for referral. So as I said in my presentation, it can be in the beginning or at the end or closer to the end.
Okay, and can people refer themselves? Do they need to go through the GP? Or do you people just ring up the hospice?
At our hospice, we would require a GP or another health professional to make a referral. Some hospices can do receive, I think, self-referral. But I don't know which particular one, but most hospices will require at least, a health professional or a referral from another health professional.
The family support team does take self-referral for people who are wanting just psychosocial input. So if you're just wanting some counselling or maybe some support around talking to kids or that sort of thing, we have a category called psychosocial only. So people can refer themselves for that. I think it's the medical input that requires a GP referral, hey, Salina?
Yes, or oncologist, yeah.
Yeah, okay.
Because then because then we have the right information, the medical information.
Yeah. So Jeanette, I just had a follow-on from that. For your hospice family support services and the psychosocial support and things like that, in terms of brain tumour patients who perhaps may be starting to experience some cognitive decline, do you take those patients earlier in the disease trajectory or than perhaps other cancer patients?
Yeah, from a family support point of view, actually, we would much rather connect with people sooner rather than later in the process. I think our services often are more valuable when people are more well. So, yeah, absolutely. Our criteria are probably slightly different from the medical ones in that sense. And I think, yeah, certainly we'd rather hear from people sooner rather than later. You still have to have a life-limiting illness, but we probably wouldn't be thinking about whether you were in the last year of care or anything like that. It would be more just that you've got a life-limiting illness and some need relating to that.
And sometimes, I mean, I think, when going back to the referral question is, even if even if it is quite early, we might be, often more often than not, then we're able to do a single intervention, and then hand you back over to oncologist or the GP, and then somewhere down the line, the needs increase or the needs changes, and then a referral can happen, and then so there's no hard and fast rule.
Right.
Yeah.
Right. Okay. I'll get to start getting to the questions in the chat box now. Here's one. My question is the decision criteria of the oncologist. What is considered by the oncologist to promote chemotherapy versus palliative care? I'm not sure if that's a question that either of you can answer. It's, I guess, yeah, that's a difficult one.
And I think that's, sometimes when there's nuances about chemo or versus supportive care only or palliative care only, that's when the hospital palliative care team can get involved, because there is a complex decision making, and sometimes it can be complex communication. So the hospital palliative care team can be involved in that sense to navigate that conversation. Yeah.
Okay. Do you have a web address for the advanced care plan you showed us?
Oh yeah, I can send that along to you. Yeah.
Yeah, I guess as a general question, where do people get advice on advanced care planning?
Well, the primary care team definitely should have the resources
So most GPs would have access
to have access to that
kind of service, right?
Yeah, like for example, for in Hutt Valley, we do have funding to well, actually most I think in Hutt Valley the GPs have funding, the access for extended consultation to help the patients to complete the advanced care plan. And it does not necessarily have to be the GP, it could be the practice nurse.
Okay. Another one about advanced care plans. Is an advanced care plan legally accepted as a patient's wishes, or must an EPOA also be required to be enforced?
You answer that, Jeanette.
Yeah, I'll start anyway. So
yeah,
an advanced care plan is not a legally binding document. So yeah, I mean, certainly you need to have an enduring power of attorney for that to be legal. I mean, I think with an advanced care plan, the intention would be that as much as possible that was adhered to, or that the person's wishes were respected. And if you had an enduring power of attorney, the expectation would be that they would follow the wishes in your advanced care plan as much as possible. But yeah, it's not a legal document, and you do need an enduring power of attorney if you want something that's legal.
Okay. Thank you for that. Another one, my question is about end-of-life funding. We were told that Mum was eligible for 6 weeks funded end-of-life care. However, once she entered residential care, she was no longer able to access this funding.
I'm curious as to what part of the country that question has come from. We in Wellington, for instance, there's no such thing as end-of-life funding, but I know that in Canterbury that people have accessed end-of-life funding. Or I shouldn't say there isn't end-of-life funding, it's just administered differently. So there are parts of the country where it's administered so that people do get this free block of funding. And certainly in the Wellington region where we are, the funding is absorbed into different services and funded that way. So I think we've had people that have come up from Christchurch that have felt a little ripped off in that sense. So I can't specifically answer you about why that disappeared when you went into aged care, because we don't have that in Wellington anyway.
Yeah, they're saying they're in the Coromandel.
Okay, yeah.
So I don't know which hospice network that is, or which
yes, Thames Hospice.
Who provides that funding, Jeanette?
It's Ministry of Health funding. So and it just seems to be to the regional authorities how they administer it. So yeah, it does seem unfair that it's administered differently, I think. Yeah. But it is, yeah. I mean, usually if people have respite funding in place, then when you initially move into aged care, that tends to be fully funded. And then obviously that shifts when you're assessed for permanent care. But yeah, the end-of-life funding is a separate fund and it is applied differently across the country, unfortunately. It would be worth ringing your local hospice and seeing if they could talk you through that.
Yeah, they're saying they don't have a hospice close by. I guess there are pockets of New Zealand that, they may be covered by a hospice, but if you're, physically, geographically quite a distance away, it becomes quite difficult logistically. And I guess that does open a can of worms in terms of variability around the country, and also how hospices do interact or interface with aged residential care, because we have a lot of people, I think, asking the question about if they can't get into hospice, can they, what sort of aged residential care facilities are available to them, funded, or whether they have to pay privately. Sorry, Salina, did you have a comment?
Yeah. So in terms of if you want to find out the Thames, which hospice covers the area, you can go to Hospice New Zealand. I can send you the link, Hospice New Zealand website, and on that it's got a map of New Zealand, and you click on where you are on the map, and then it tells you which hospice serves your area, and it's got the contact details for the hospice as well. So I can send you that link as well.
Okay, thank you for that. Another question from the chat box. Thank you both for your presentation. Salina, I'm not sure I heard you correctly. Did you say hospice don't get involved in rehabilitation? What about the concept of palliative rehabilitation? Certainly not the traditional sense, but there is need to maintain function and allow for rehabilitation for people when they can.
Yeah. I mean, in general, our in terms of like rehabilitation, like intensive rehabilitation, we are not resourced to do that. So our not all hospices are allied health. So we are very fortunate we have a part-time physio and a part-time OT to be able to run some sort of, you know, exercises or rehabilitation or maintaining function. But intensive rehabilitation is not, it's something that is not consistently applied across hospices. Actually, we wouldn't consider ourselves as specialists in rehabilitation, right? There is a concept of palliative and rehabilitation, but it's very much maintaining current function and rather than necessarily gaining function, and using equipment to promote independence.
Yeah, so
on that diagram is really looking rehabilitation in survivorship. The diagram I showed is really talking about survivorship, rehabilitation and survivorship. And hospices predominantly look after patients in the last days and last weeks towards that spectrum. Yeah.
Yeah, so rehabilitation earlier on in the disease trajectory, for example, you know, coming out of surgery and things like that. That's really the hospital's responsibility, right?
Yeah, that's right. That's right. Yeah.
Yeah. I hope that answers your question, whoever posed that one. Another one from the chat box. My wife has a concern around strangers. How do I introduce strangers into the concept of palliative care for her?
Is that, I'm just sorry, is that the idea that having new staff come in from palliative care would feel strange? I'm just trying to understand the question.
I assume so, yeah.
Yeah.
Sorry, it's probably more strangers in the house.
Yeah, sure. Yep. And that is tricky. That's that's a real issue for a lot of people, is that, you know, you can feel that your life's been overtaken by caregivers and hospice staff. And so, I mean, I think certainly, thinking in terms of our hospice input, that we would just try to be really sensitive to that. And I think if you flagged that up front, they would try to give you consistent people so that you were, you know, getting used to whoever was coming. Just doing whatever we could to kind of manage and minimize the intrusion in the home. But it is an issue. It is, it is yet another service and yet another person to introduce into the situation, isn't it?
Thank you.
Yeah, I think a lot of people actually, have a level of anxiety which is probably greater than someone that doesn't have a brain tumor, to be honest. And so it's just taking things slowly to earn that trust slowly, I guess. And as you say, it would help if it's the same person coming each time, so that they can slowly build that trust. And it must be quite difficult when you have different people coming and lots of different people. But I guess there are different people in the team, so.
It might also be, David, that the palliative care could be kind of focused through you, perhaps, like that there might just be a bit of a workaround there to give, you know, the best palliative service that can be delivered without perhaps necessarily having that same level of patient contact that we would have if there wasn't that same level of anxiety.
Thank you.
I don't see any more questions in the chat box. If someone has posed one and I've missed it, feel free to speak up. We have a couple of minutes left.
Jenny's waving at you, Chris.
Jenny, take yourself off mute.
Sorry. Yes, I did post a question in the chat box.
Oh, I'm sorry, I must have missed it.
If you like, I can read it.
Yep, please do.
Okay, up here. I just said, given that New Zealand is in the middle of a GP crisis, particularly in rural areas, can hospice in any way step into the gap? That's my experience. My GP practice is now down to one single GP, and my personal GP is now retired. Self-referral for me might be important. Is there any way that can be a workaround?
I think, you if you can ring up your local hospice, because I think, as I say, some hospices do accept self-referral, there's resource limitation in primary care, and also hospice care is also there's limitation across the health system, I guess. That's what I'm trying to say. And so I suggest that you call your local hospice and see what services that they can provide for you. I know some, depending on which area, in some hospices there may be 2 or 3 nurses without a particular rural area, and they rely on even telephone consult. They don't have doctors. They telephone consult from another hospice, the bigger hospice in the region, to provide that the medical input. So some hospice team can be very small as well in the rural area. Sorry, I can't give you any definite answer on that. Yeah.
Yeah, it is a problem finding GPs though in some areas, isn't it? So, thank you, Jenny. Well, I can't see any more questions. If anyone does think of questions that they want to ask Salina or Jeanette, please feel free to email them to us at hi@braintumorsupport.org.nz, and I can email those and email you back the answers from Salina and Jeanette. But we'll wrap it up now, and I'd just like to thank everyone for coming, and also special thanks to Salina Iupati and Jeanette McLaughlin, our 2 speakers this evening. Thank you both for excellent presentation.
Thank you, Chris.
Thank you. Thank you for having us.